It's quite difficult as a pathologist. You do get sort of detached from reality because you're looking at a piece of tissue and just being able to sort of correlate and understand that there's a person at the other end that is being affected by what you're doing is quite an eye opener, really. And today I've got about half an hour or so, and I'll try to cover whatever I can in terms of explaining the role of the pathologist and how involved we are in your care and your diagnosis, but also how difficult it is to diagnose salivary gland cancers as well. So I'm an academic pathologist based at University of Sheffield and Sheffield Teaching Hospitals. I'm also the clinical lead for the pathology service there. And I'm also a patron for the Swallows Head and Neck Cancer Charity. So I feel like, I'm sort of preaching to the choir here, but salivary gland cancers, of course, arise from salivary glands. And as you know, we tend to split them into two categories, basically, major glands and the minor glands. And the major glands are the ones that are present on either side of your face or mouth, and they produce the bulk of the saliva in your mouth. So the biggest one is the parotid gland, which is just in front of your ear. And the next largest is the submandibular gland, which is just under the jaw in the neck. And the third one is the sublingual gland, and that's just under the tongue in the floor of your mouth. But in addition to that, there's a lot of minor glands also scattered throughout your mouth. And the purple areas here actually indicate where you can find minor glands. And in the mouth, you can get up to 1,000, if not more, minor salivary glands. And if you ran your tongue along your lips, they feel a little bit lumpy and bumpy. And all those little bumps are actually minor salivary glands sitting in your lips. And they produce 5 to 10% of the saliva in your mouth. And of course, they can also get cancers. So just to explain the salivary glands a little bit more, the structure of it, and not sure whether that reminds you of something, but in my eyes, it looks like a bunch of grapes, really, and that's pretty much the main structure. So of course, you have a surrounding capsule or the main structure of the salivary gland, but this is the basic unit of a salivary gland and how saliva is produced. And these little end sort of areas are the ones that produce the saliva, and then is pushed into these little tube-like structures and ducts, then into bigger tubes, and then the largest one, which actually carries it to your mouth. And any of these structures in the salivary gland can actually develop a cancer. And of course, you've got two different types of tumors that can involve salivary glands. So they can be benign. Benign tumors usually quite well defined. They tend to have a capsule around them. They don't spread to other parts of the body. And they are easier to treat, where malignant tumors are more aggressive. And they can go into the structures next to the salivary glands, but also travel to other parts of the body. And they can also come back more as well, so they're more difficult to treat. So today we'll be focusing more on the malignant tumors, which we refer to as cancers. So a lot has changed for salivary gland cancers and tumors over the last 30 to 40 years. And this is basically the Bible for a pathologist who is diagnosing salivary gland tumors, the World Health Organization classification. And this basically tells us how many types are there and main features and sort of investigations that you can use. So if you go back to 1972, things were a bit simpler and there were only 10 tumors identified at that time. Adenoid cystic carcinoma was still in there though. And if you look at the 2017 most recent classification, now we have over 33 tumors. So you can see the number is more than tripled. And since 2017, actually 4 or 5 new tumors have already been described, which will make it into the next book in 2021. This shows you it's a very rapidly changing field. So as a pathologist, we need to be on top of really everything with the knowledge and awareness of these new cancers, so we can make the right diagnosis and help the patients. One issue with salivary gland cancers or tumors is that the data available is not great. So most of the studies that are out there are 1 center or 2 centers. There's not that many multi-center studies, and that's something we're actually working on. So Ibrahim, who's on the call, who's doing his PhD with me, we're actually collecting data from 10 to 15 national and international centers. So far we have about 3,000 cases, and out of these, 1,000 are malignant. So that's a 64 to 36% split. And in this cohort, the split between males and females is fairly similar, slightly more common in females, the malignant cancers. And when we look at the tumor types, the most common one is mucoepidermoid carcinoma, which is also the one that's been described in the literature as being more common. But of course, there are other ones that you are more familiar with, like adenoid cystic carcinoma, 13%, polymorphous adenocarcinoma, etc. The age distribution is fairly wide, but 40 to 79 years of age seems to be the most common group. However, it can involve younger and older patients, and even children. And in children, again, mucoepidermoid carcinoma seems to be the most common one. And in terms of site, the parotid gland is the most common site, but other sites in the head and neck can get involved. I mean, a few you mentioned the tracheal cancers. In my so far, I've come across tracheal adenoid cystic carcinoma, so that was really interesting and educational for me. But the next most common site is actually the palate, so you can get malignant cancers quite commonly on the palate as well. So how do we actually deal with things in the UK, and what's the sort of guideline or pathway? So once you're seen by your doctor or dentist or whoever suspects that you have something sinister, you refer to a hospital, and that's when a 2-week clock starts. And within those 2 weeks, you should be seen in the hospital at a sort of specialist center. After that, you'll have your biopsy and further investigations. By day 24, you should be informed of your diagnosis. And by day 31, we should have a decision on how we're going to treat it, and you should be informed of that as well. And before the end of the second month, you should have received your first definitive treatment, whether it's surgery, chemo, or radiotherapy. Now, you'll be quite surprised to know that pathologist is pretty much involved all along the path, although we're not very visible. So when you first seen and you have the biopsy, that specimen comes to us and we make the diagnosis. Based on that diagnosis, your treatment will be decided, okay? And then whatever treatment is done, if it's surgery, then that cancer will also be sent to us. And then we'll look at a number of different features, which I'll talk to you about later, which will determine how you followed up or whether you'll have any further treatment. So as I said, pathology is the study of disease, basically, and it forms a cornerstone of your treatment. And the branch that we're dealing with here is called histopathology. So that's basically looking at tissues down a microscope. And that's to confirm the diagnosis, the subtype of the tumor, and also try and predict how a certain cancer may or may not behave. And the biopsies can be multiple types, or they can be sort of an incisional biopsy, which is like using a scalpel, or if it's in the parotid, you may have heard about or have experienced a needle aspirate, or tissue core biopsy, because it's deeper in the tissue and it's more difficult to get access to. Once it's removed, then we actually look at whether it's completely removed and are there any things that can tell us whether it's going to come back and how likely it is to come back. So you can be offered the appropriate chemo or radiotherapy or anything else. So that's the sort of overall pathway of, I would say, your cancer or the specimen or the pathology workflow. So if you start with the biopsy and the referral, all the blue boxes here with the dotted lines are the ones where the pathologist is involved. And all the red boxes here are the ones where the pathology lab is involved in terms of lab processes. So you can see quite early on when you have your imaging and biopsy, we get involved. And then you've got a whole sort of parallel pathway running in the pathology lab, where I'll briefly explain some of these steps as well and what we do with the specimens. But in addition to that, of course, diagnosis and discussion at the MDT, we are involved in that. Your treatment, as I mentioned, any further surgeries or treatment as well, and even follow-up. So a biopsy can be in the form of a little bit of tissue removed from here. For example, this is something inside the mouth, or like I said, a core or a fine needle aspirate from a parotid gland or a submandibular or any other gland. And that specimen is then placed in one of these pots, and that's got a solution called formaldehyde. And formaldehyde, what it does is basically it preserves the tissue in a lifelike state. So it doesn't allow it to break down, because as soon as you remove tissue from the body, it will start to die. So this solution will stop it from dying and it will just preserve it. And that form is sent to us. We receive it in the lab, we look at it, and we trim it and slice it as needed, describe it. And that tissue is then embedded in a little cassette with hard wax. And that is then mounted on this little machine, which we call a microtome. And then you get really thin slices of tissue from that. And those thin slices of tissue are then put on a glass slide, which then goes through this machine called the stainer. And that runs automatically. So in about 20 to 30 minutes, the slide will go through. And at the end of it, you will end up with a slide which looks pink and blue. So the main stains that we're using here are pink and blue. And that helps us identify different features of where the tumor is. For example, here is a tumor. There's some background tissue and different cells, or the sort of structures of the cells have got different color. And we can use that to analyze. So what sort of things do we look for? Of course, we try to look for and identify the subtype of the tumor and behavior of the cancer. So adenoid cystic carcinoma, as you guys have mentioned, is one of the more common ones. The most common pattern that we see is this cribriform pattern that's also been referred to as like a Swiss cheese-like pattern, because you've got these like punched out holes in this cancer. But there are other times where we see different experiences with more solid pattern. And this, you don't see these holes that you're seeing on the left side, or you can even get little tube-like structures. In our experience, this one, the solid one, is the most aggressive one or worst behaving one compared to the other two. So it's quite important to identify those features. But the problem is there are a lot of other salivary gland tumors also show a similar sort of pattern. So it can be even benign tumors that show a similar pattern, other malignant tumors that show a similar pattern as well. So it's very important for us to actually make sure we get to the bottom of it and make the right diagnosis. So for someone like me, this is what's going on in my mind when I see something like that. So that cribriform or Swiss cheese-like pattern. All of these strange sort of names and sort of abbreviations that you're seeing are basically for markers or specific things that we look for, or special tests that we can request to get to the final diagnosis. So you can see there's like a very sort of algorithmic type approach going on in your mind, and how are we going to get to the final diagnosis and decide whether this is an adenoid cystic carcinoma or something else like a salivary duct carcinoma or even a benign cancer. It can be even more difficult if you've got a specimen which is just a fine needle aspirate. So from the needle, you can only get a limited amount of tissue. And here you can see only these cells here are actually the tumor, and the rest of it all is just background immune cells. So basically, all we have is this, and we have to make a diagnosis on the basis of this, whether you've got something benign or malignant, and what sort of treatment should be offered. So it can be quite challenging. Other times, needle core biopsy is done, and we actually in Sheffield have completely stopped doing fine needle aspirates because needle core biopsies are much better. They give you a bit more tissue, and you can do some more of those investigations and actually get to the right answer without having to repeat the biopsy. Then another common one is, of course, mucoepidermoid carcinoma. And in this, the things we look for, one of the common appearances, that these cells look very pale. So they almost look like they're see-through. Some of these cells look more pink, you can see here on the right, but others look very see-through, and that's what we call a clear cell pattern, that this looks like there's nothing inside the cell. So you would think, okay, that's quite a nice feature that we can use to identify these cancers. But the problem is, again, that there's at least 10 different types of salivary gland tumors that can show those clear cells. So actinic cell carcinoma can have them, clear cell carcinoma can have them, and even 4 or 5 benign tumors can show those clear cells as well. So again, in my mind, or in any other pathologist's mind, we're going through all of these different decisions and tests about establishing whether we are making the right diagnosis. Other things that we look for is how far the cancer has spread beyond the capsule of your gland. And this applies more to your major glands like parotid and submandibular gland. And we use it more for carcinoma and pleomorphic adenoma, which is one of the malignant cancers. So this cancer can just be within the capsule, which means it's got a good behavior. It can be minimally invasive, which means it's gone about 4 to 6 millimeters beyond this capsule. So this is this little fibrous sheath which is holding the cancer in. And it's only gone a little bit beyond it. We have to measure it and we have to give that measurement. Or it can be widely invasive, which means it's gone quite widely into the surrounding gland. And why is that important? Because there are plenty of studies which actually show us that both the intracapsular and minimally invasive types actually have got very good behavior. So we can actually feed that information back to the surgeons and the oncologists so they can actually decide how best to move forward and also pass on that information to you. Whereas if it is widely invasive, then its prognosis is poor because they're more aggressive and they already have extended into the surrounding tissue, which means they're more likely to metastasize and spread to other parts of the body, and the survival can be lower as well. We also try to grade the cancer, and grading is like giving a score. So pathologists giving a score of behavior, basically. And it helps, again, the surgeons and oncologists to differentiate tumors that may do well and compare them to those that may not. The problem with grading is that it's done on biopsies by pathologists, and it depends on your experience, how many of these cancers you see, and it's also quite subjective. So it's not like a mathematical formula. There's a lot of sort of feel involved as well, and experience, and you sort of eyeball something and you give an overall idea of what you think the grade is. So there's a lot of variation between pathologists, which can be a problem. So some people have suggested that maybe grading isn't that important, and there is evidence to suggest that the size of a salivary gland cancer is probably one of the most important predictors of how it's going to behave. And that is true in quite a few cancers, but we still consider grade in almost all salivary gland cancers, and in particular, mucoepidermoid carcinoma, adenoid cystic carcinoma, and of course, adenocarcinoma and acidic cell carcinoma. So how do we grade and what sort of things are we looking for? So if we take adenoid cystic carcinoma, as I mentioned earlier, you can have low grade or high grade cancers, and there's an intermediate grade as well. So when you get that punched out appearance that I mentioned earlier, which looks like Swiss cheese almost, these are meant to have better behavior. So these are low grade cancers, whereas high grade cancers are more solid, which means they look more blue. They don't have as many holes in them. And we feel like that these are more difficult to treat. And historically, there's been a 3-grade system for adenoid cystic carcinoma. So grade 1, 2, or 3, or low, intermediate, and high. And what people have suggested that grade 1, which has got mostly the cribriform appearance, this one has got quite good behavior. Grade 3, which has got more than 30% of these solid-looking areas, has got a worse prognosis. And then this grading system suggested that anything in between should lie in the intermediate grade. Now, the problem with this grading system was that 3 grades always create a lot of problems. A lot of people sit on the fence and go for grade 2. It increases the subjectivity, and it's not like a binary scoring system. So to overcome that, recently, a more sort of simpler approach has been recommended, that we should just look for solid areas. So anytime we see this dark blue appearance and not the cribriform appearance that you saw here, presence of any of these areas should make something high grade. And this paper actually showed that, and they also showed that using this grading system, there was 100% agreement between the pathologists. What they also showed was, so this is like a survival curve over a few months, I think about 2 years, 3 years. So basically, the higher the graph or this line, the better the behavior and the better the survival. And the lower down it is, the worse the survival or the behavior. So if you look at the solid positive tumors, you can see that the survival and behavior is worse compared to those that lacked any of the solid areas. So in our practice now, we actually just, if there's any solid area, we just say this is high grade, it should be treated a bit more aggressively. Other things that we look for is whether the cancer is spread locally in the tissue. So these fragments here are bits of muscle, and the dark blue cells here are actually cancer cells, and you can see that the cancer cells are embedded deep within the muscle. So once it's bursts out of the salivary gland, it can go into any of the surrounding structures. It can even go, another example of this is an adenoid cystic carcinoma from the sublingual gland, so under the tongue here. But you can see, although it started off in the sublingual gland, it has actually gone beyond that and is now gone through the entire tongue. And this is the surgical cut which have inked green, and you can see that the cancer extending all the way to that margin. And based on that, of course, the extent of the cancer, we also determine the size of it as well. We look at whether the cancer is spread into bone, because of course that makes it more difficult to treat, but that also increases the clinical stage of the tumor. And we also go through any of the lymph nodes that may have been removed as part of your treatment. So if it's something which is in the floor of your mouth or sublingual gland, then maybe lymph nodes will be removed from both sides of the neck. Otherwise, they might be just removed one side. And we have to go around and fish every single node out of these neck dissections and look at them under the microscope at high power to make sure that we're not missing anything if there's any cancer. And sometimes you can have very, very small cancerous deposits, but it's very important to actually determine the presence of that so you can get the right treatment. And based on all of that information, then we give a final report, which will include things like the size of the tumor, how far beyond the capsule the cancer has gone, how close it is to the margins. That means the surgeon actually tried to remove it and made the surgical cut. Is it far away from it? Is it close to it? Or is it actually at those cuts? Where the tumor has gone into bone. And of course, once the cancer gets into your nerves and blood vessels or lymphatic vessels, that means it can spread to other parts of your body as well. So it's our job to look at every bit of tissue and establish whether it is present or not. And as I mentioned, the neck dissection will determine the number of nodes and how many are positive and what's the size of those deposits as well. And based on that, we give a TNM stage, which is the pathological, and the true TNM stage. And T stands for tumor, which is tumor size. N is for nodes, and in the salivary gland cancer, predominantly is nodes in the neck. And M is metastasis, and that's to other parts of the body. And this system is used just so all the clinical team members speak the same language across the world. So TNM staging is the same whether you're in the UK or in the US or anywhere else in the world. And it just becomes a lot easier to convey information and standardize it as well. But a lot of the time we have to do extra investigations because based on just those pink and blue slides, we can only do so much because not everything is visible to the naked eye. So there are special markers that we can use, which can be to actually differentiate between the different types of cells or how active the cells are. And that's using a technique called immunohistochemistry, which you can see here. It stains the cells brown. And the brown positive cells are actually, this technique is amplifying the signal. So something that I can't see with the naked eye is actually boosting the signal and making it visible for me and helping me make a diagnosis, which is going to affect your treatment. But there's also a step beyond that. We can also look at genetic markers, things that are not visible at all. And what you have to do is actually probe your DNA or even RNA at the gene level to see if there are any changes in there that can help us with the diagnosis. And of course, expert opinion, which is quite important as well. So one thing about salivary gland cancers is that our understanding of them is improving quite rapidly. And there's a lot of knowledge now about the genetic changes that are present in these salivary gland cancers. And these are just some of the ones we know about. But most of the time, these are still being used for diagnosis, and not many are being used for treatment or therapeutic purposes. So just an example of this is an actinic cell carcinoma, and this is what it looks like under a microscope. And we call it actinic cell carcinoma because acini are those grapes that I showed you earlier are basically acini, and this tumor is derived from those grape-like structures, and that's what they look like. They look slightly granular, so they don't have a smooth appearance, and that's how we can tell that they are acinar, and they're the saliva-producing cells. But there are special stains that we can use in the lab, which actually highlight the enzymes within these cells and help us confirm the diagnosis. There are the special markers as well. So this is a marker DOG1, which was known to be or thought to be only expressed in gastrointestinal tumors for many, many years. So we did a big study a few years back and actually showed that in actinic cell carcinoma, this very, very widely expressed. So the brown staining that you're seeing, the brown color that you're seeing is a positive reaction. And not many other salivary gland cancers actually show this marker. So it's very useful marker to differentiate at least ascenic cell carcinoma from some of the others. And this is another one that we use quite commonly, and it's called Key 67. And what this one does is basically highlights or colors any cell that is actually dividing within the cancer. So cancer cells inherently are more rapidly dividing than normal cells, and malignant cancers are even more rapidly dividing than benign cells. And using this marker can actually give us an idea of how many of the cells are actually dividing right now. So in this case, this ascenic cell carcinoma is actually a high-grade cancer because over 80% of the cells are actually dividing, which tells me that this is quite aggressive and needs to be treated aggressively as well. The importance of expert opinion, I just thought I'll show you one or two examples. So this is a case that was sent to me by a very experienced pathologist for second opinion involving the parotid gland. Here is a little bit of the parotid tissue at the bottom, but the bulk of the specimen is this thing here that you can see. And there's a little fibrous capsule, as I was saying earlier, around it. It's like a little sheet around it. And they sent it to me to just double check and say, I've signed it out as a mucoepidermoid carcinoma. Can you please have a look and confirm that? So I had a look at it and I thought, this doesn't look right. Although it's got that clear cell appearance that I showed you earlier, that the cells are see-through, there's nothing inside those cells. The pattern is, it's got sort of lots of these little packets, if you can see. It's got these little round packets clumped together very closely. And this reminded me of something which has got this characteristic appearance. I'll show you the final diagnosis in a bit as well. And the other thing was that this wasn't really involving the parotid. It seemed like it was just sitting next to the parotid gland. And there was no evidence of any salivary tissue within or next to the cancer. And it was also present in a big blood vessel as well. So a mucoepidermoid carcinoma, particularly that has got these clear cells, is usually meant to be low grade and doesn't show these features. So straight away, I requested this marker, which is RCC, which is renal cell carcinoma, and it came back diffusely positive. So this was actually a cancer from the kidneys that had actually shown up in the parotid gland. So I called this other consultant and told them to do some further work on this patient, and the patient didn't have any previous history of renal cancer. And what they found after the scans was that they actually had 2 cancers sitting in both the kidneys that no one knew about. Another example of this 52-year-old male patient, and this was sent to us as a provisional diagnosis of a carcinoma in pleomorphic adenoma. The patient had a surgery plan, so they were going to remove half of the maxilla and also do a neck dissection. And their rationale for that was that, of course, yeah, you've got a lot of these tube-like structures. It looks what we call busy. So it's got a lot of cells in it. And the cells look variable in appearance. So as you can see, some of the cells are darker. They look more blue. They're also bigger as well. And that variation is usually a sign of cancers that you can use to help differentiate. But there were other features in it that made me realize that I don't think this was actually a cancer, because some of those features have been described in a recent phenomenon or a tumor which is benign. So although it looks malignant to the naked eye, or many experienced pathologists even, it's actually a condition called sclerosing polycystic adenosis, who actually wrote back to them and told them to stop and hold back from the surgery, and that this was just a benign thing that they have removed already, and all they needed to do was just wait and watch. So just to sum it up, we are pretty central to your diagnosis and your treatment, although you never see us or never hear about us. But you can see that the task is very difficult. There's so many different cancers, and this shows so many similar features. And within the same cancer, you can get many different types of features as well. So it requires a lot of experience and also access to some of these special tests to make the right diagnosis and make sure that we actually help you in the end and make the right diagnosis. And I believe that this second opinion or even third or fourth opinion, so the expert opinion, is very, very important, because no one in this world knows everything. And if you have any doubts, I think it's always a good idea even to go back to your surgeon oncologist and say, has this been seen by more than one person, for my peace of mind? Because I think for salivary gland cancer is very important that happens. And thank you very much for listening. I hope that was useful.